No. Yes, now it's working. Thank you very much for this kind introduction, and it's a pleasure to be here in this huge hall to discuss with you the problems families with ADHD children face, problems parents have to face, other siblings have to face. But before starting to talk about the survey, first my disclosure slides showing my connections with various types of companies, as well as my research funded by other governmental and non-governmental agencies. Before talking about families, I like to make some introductory remarks. And my first point is that ADHD is a real developmental disorder. And developmental disorder means that the symptoms are differently expressed over age. And that, for example, problems of preschoolers are different from problems of school-age children, from adolescents, from college-age students, and from later adults. In preschool, more behavioral problems, aggression at the behavioral level, oppositional behavior, of course hyperactivity, problems of motor control, are most striking symptoms of preschoolers with ADHD. Then, entering kindergarten, entering primary school, they are starting learning processes, and then may arise academic problems, social interactions with peers may become more and more problematic, and although social problems are not part of the key defining problems of ADHD, many children with ADHD have persisting problems with social interactions that are for some rather similar to children with autism spectrum disorder and need special types of treatment. It's very challenging for the environment, and those are, I think, particularly the type of children who have few benefits from all kinds of psychological or behavioral treatments. Again, in adolescence, the expression of the symptoms may a little bit change. We have more problems with substance abuse, academic problems with social interactions may intensify and aggravate, low self-esteem may arise, and we get all kinds of problems like smoking rates increase, alcohol use increases, and even traffic accidents may be a significant problem. And how to deal with the adolescent with ADHD who's like to drive a car, like to get a driver license, is using alcohol sometimes, is not using his medication in a very compliant way. How should we deal with this? It's a significant problem for parents, teachers, and all other adults dealing with these youngsters. Then we have new problems when they enter college age, again academic problems, and up into adult age we have relationships problems, a higher divorce rate, low self-esteem, employment problems, low dropout in school, and so a lower number of certificates. And so, although severity of problems, of symptoms, primary symptoms may change over time, and particularly hyperactivity and impulsivity may improve a little bit, inattention is very persisting, and all these kinds of associated problems may be very persisting into adult age. What is the main target of treatment? The main target of treatment is to minimize symptoms and associated impairments. And many studies, the MTA study, but also many other studies, have clearly emphasized that the key avenues to treatment are medication treatment added with behavioral interventions. And of course, there may be key questions like, should we always add behavioral interventions? When should we add behavioral interventions? I will not touch upon these issues because that's another lecture, but in principle, the long-term efficacy of treatment depends to a very large extent on the systematic maintenance of medication treatment, and particularly the follow-up studies of the MTA up to 36 months after the initiation of the study showed that the maintained drug treatment is very important for sustained effectiveness. When talking about medication, and this afternoon I was at the railway station and I saw all the people in the street talking about medication, yelling about medication. I thought, I talk with you about the myth of medication. I hope they are here in this meeting and I can talk to them, but I'm thinking they will not be here, but you can get a good message. There is a lot of myth about medication. And so the first myth is that medication is antagonistic to good parenting. People may thinking, well, we should add the parents, but by giving medication to the child, that's a very poor substitute for poor parenting. That's I think, a myth. I will return to each of these myths later on. Many people think, or may think, also the people yelling in the street, the demonstrants, that medication is just doing something wrong, because ADHD, they think, it's an emotional problem. And when a child has an emotional problem, is worried, has anxieties, has problems with his self-esteem and self-identity, how can you medicate that? You should talk, should good breathe, psychotherapy, play therapy, be in touch, be in communication with the child. You should not medicate. I think that's a myth. Then, many people say, well, by bringing medication to the family, you decrease their motivation to really work. People may be more passive and wait and see till the medication is effective. And I don't think that's true. Then, it doesn't solve the problem. There is really, you should listen to the child, you should go to the key. Has the child been traumatized? Is there a family problem? Is there a key emotional or life event problem? That should be solved. The medication is just too superficial. I think it's wrong, it's a myth. People say medication is overprescribed, and I don't think that's true as well. And finally, many people say, well, starting medication, all good, but we don't know even the long-term effects and safety issues of the medication. It's not a poor substitute for parenting, but indeed, many parents become better parents when the child is on medication. In fact, much evidence indicates that good medication stabilizes the condition, and parents are becoming more effective parents, also more effective in being, for example, in parent training or parent guidance groups when the child is on medication. ADHD is, in fact, not an emotional problem. We have a lot of evidence. I will show some of one or two slides, but it's in fact a biological problem of the brain, and it's not an emotional problem. Many parents are more motivated to participate in behavioral treatment and parent training when the child is on medication, so it enhances participation. It doesn't solve the problem. By contrast, reality is that medication improves the care of children with ADHD. The data there do suggest that there is more underprescription, both in the UK and in Europe, in the continent, and there may be niches, local niches of overprescription, but underprescription is more general than overprescription. And finally, we don't know the long-term effects. It's quite incorrect. We have now data to support at least efficacy and safety, partly under placebo-controlled conditions, for over 2 years. And also long-term treatment showing no effects on hormonal systems, no severe effects on height and weight, and no severe effects on brain volumes and brain development. I started to tell you that ADHD is a developmental problem, a psychological developmental problem, a behavioral developmental problem, but I think ADHD is also a problem of brain development. And I will not have the opportunity in this lecture to go into all the details about ADHD and brain development, but this is just to show you the summary graph of the very famous study by Castellanos et al. Showing that boys with ADHD have just smaller brains than healthy boys, and girls with ADHD have somewhat smaller brains than healthy girls. And this difference is about 3 to 5%. It's for the general brain volume, it's also for the prefrontal lobes. And the key message is that this difference is rather stable over time. There is new, very exciting data to suggest that also cortical thickness is different. You can measure the thickness of the cortex on MRI scans, and the thickness of the cortex is thinner in children with ADHD, particularly in the prefrontal and precentral areas, and that are the areas particularly involved in attentional control. And the thickness of the cortex is a prognostic indicator for outcome several years later. So brain development and the biology of ADHD really matters. This is to show you, in a study from the Netherlands in which we participated, that also unaffected siblings have smaller brains than the controls and as small brains than the patients. This slide, in addition, let me explain it to you. These are the patients, these are the brain volumes, these are the controls, and on average the patients have smaller volumes than the controls. But this also shows you the scatter, the variation within the group. So it's a group finding, the smaller brains, meaning that MRI scanning, all sophisticated brain imaging, doesn't help you to have a diagnostic biological test. It's just a group finding. But unaffected siblings without any symptom of ADHD have as small brains as their affected probands, and smaller than the controls. Suggesting, because siblings have on average 50% of the genes in common with each other, so suggesting that the smaller brain may be what we call an endophenotype of ADHD, a hidden biological marker of ADHD, a vulnerability characteristic of ADHD. And talking about genes and brains, we were also able to show that two risk genes for ADHD, the dopamine transporter, the DAT risk gene, and the DRD4 risk gene, were associated with smaller brain volumes. For example, we knew that the dopamine transporter gene is particularly expressed in the basal ganglia. And we reasoned that those with the two risk alleles, the homozygous for the 10 repeat, would have smaller caudate nuclei compared to those without. And that did become true. Smaller, significantly smaller than those without the two risk alleles. And the DRD4, the novelty-seeking gene, with the repeat allele, is particularly expressed in the prefrontal cortex. And we reasoned that those with the combination of the risk alleles would have smaller volumes of the prefrontal cortex. And indeed, that became true compared to those without the two risk alleles. So we have now made progress in starting just to look at significant associations between the risk alleles, the candidate genes, and brain volumes. When talking about genes, you have always the question, what's really important, the genes or the environment? And I would like to say both are very important. And so when talking about genes, you have immediately your attention also switched to environmental issues. And this is just to show you the interaction between genetic risk factors and the environment. This is data from a large prospective birth cohort study of children now 15-year-old in Germany from a community sample. And they were subtyped into those with the risk combination risk gene of the dopamine transporter and those with low or high adversity of the environment. High adversity meaning parental divorce, parental psychopathology, all kinds of family problems. And on this vertical axis is the percentage of those with significant hyperactivity, impulsivity problems. So though this slide shows you when there is no genetic risk, adverse environmental factors doesn't matter very much. It doesn't affect, and there is no difference in hyperactivity, impulsivity. However, in those with the genetic risk combination, those with the environmental risk have the much increased risk for being more hyperactive and impulsive, indicating that it's likely that for many genes it's likely that the combination, that's not a main gene effect, but it's the combination with environmental risks which increases the risk for ADHD. So all genetics and all brain imaging and all neurobiology of ADHD doesn't diminish the interest in environmental issues, but by contrast should increase the interest for environmental issues. And this is just to summarize to you that one of the main challenges is then to explore the associations between the symptoms and between all the psychiatric comorbidities present in children with ADHD, all the comorbidities like anxiety, depression, disruptive behavior disorders. We may add autism spectrum, we may add tic disorders. And so all the effects of those symptoms and comorbidities into the development of the child and the family and the social development of the child, resulting in poor relationships, stress and family problems, as well as all risk in the child. And so I will now particularly focus on the effects on the family. And I will do that on the basis of a very large survey among European families with children with ADHD, one or more, and control children. And we developed this survey because we had a strong feeling that our knowledge about what's really happening in the families with children with ADHD was very scarce, was very lacking and very fragmentary. And particularly we were interested in how parents experience problems with their children over the day, early in the morning, at lunch, in the afternoon, in the late afternoon, and in the evening. And we also were interested to explore potential differences between children with ADHD on and off medication and with 6 and 8 hours treatments a day versus 12 hours treatment a day. And this is to show you just the design of the study. So it's most easy to follow this green bullet because we started with an original sample of about 100,000 families. Then there was a selection of more than 800 families entered into this ADHD survey. I will tell you about the inclusion criteria next to this slide. And then more than 800 with an ADHD child, and they were categorized into those with medication, more than 300, and those without medication. And there was a further breakdown into 6 to 8 hour treatment and 12 hour treatment. And as a comparison, we selected from about 18,000 families without an ADHD child a representative comparison sample of again 900 families. The ADHD families had to have a child with ADHD with a confirmed clinical diagnosis, a child between 6 and 18 years old. The parents had to be able to answer a series of questions about their child, and the child had to live in the family, the child with ADHD, so it should not be outside. And so many children of this survey, which is already a very interesting figure, 60% or more, didn't have medication, just naturalistic. So we think about over-treatment and over-prescription. 60% was not on medication, so that's reality. 38% were receiving medication, and the medication had to be stable for 3 months. This is to show you, although I will not go into all the details of comparing the medication subgroups, but in general 6 to 8 hour treatment could mean one medication for 6 hours or 8 hours, but could also be 2 immediate release medications for each 4 hours, and the same applied to the 12 hour treatment. So we were not interested in particularly compounds or branches of medication, but it was more the concept of the number of hours treated per day, which was of interest. The two groups, those with a child with ADHD and those with a controlled child, were very comparable in terms of the composition of the parents, were mostly the mothers who completed the questionnaires, the ages of the mothers, were they married or cohabiting, or were they living with one or more children. And also the ages of the children and the sex distribution was very similar. What was the topic of the questions? The questions, in fact, were developed to target these issues. Everyday activities, both in the home, just as meal times, homework, as well as outside the home, leisure time and family activities. We were interested in general behavior problems. We were particularly interested in how well the relationship between child and siblings and parents and peers and others were in the family. So about family relationships. And we were particularly interested about the times of the day that everyday activities or family relationships were interfered with by problems, ADHD-related problems. And this is just the start. I would say this is also the initial validator of the whole setup of the survey, because this shows you, not very surprising, that children with ADHD were rated as more excessively demanding than the controls, more noisy, more aggressive and defiant. They had more lack of motivation. They were more impulsive on risk-taking, more disorganized. And so many more problems. This is just because we had a difference between ADHD and non-ADHD. Which were the particular times of the day we were interested in. So we, to some extent, anchored the times of the day to specific times. So morning routines were just locked to 7 o'clock, 7 a.m., morning, and school lessons to 8. And so every question about times of the day to make the outcome comparable across families was linked to a specific time. So let me start to give you some main results of the whole survey. This is: what times of the day does your child find challenging, if any? In general, except for the early morning routine, in general, much more problems for children with ADHD compared to the controls. This starts in the morning, lunchtime, but see the huge increase early afternoon, late afternoon, early evening, late evening. So very striking differences families experience with their children, with their ADHD children compared to the controls. Second, also see the rhythm of the controls. For example, also the controls have more problems at bedtime. So that's a general problem. So you cannot ascribe every problem of your child to the ADHD status, I would say. You should also acknowledge normal development and variation across time. But this type of data is seldomly present because we don't know, in fact. We talk with parents more generally across the day and not all about all these specifics. I think this is the only slide I will present to you as an example of the breakdown of the various different medication statuses. This is ADHD without medication treatment, 6 to 8 hours treatment, the blue, and the green is 12 hours treatment. In general, this is as I showed you on the previous slide. However, remark that already in the morning and the morning routines, those on medication had much higher ratings than that child, ADHD child without medication and the control. And I think the interpretation is that those on medication were the more difficult cases, and remind that this was a descriptive, naturalistic study and not a randomized study. And then also we have for all the medication status groups the differences across the day between the normal children and also in the evening. What were the most challenging problematic activities? Homework was very problematic, following family routines, and playing with all the children. Huge differences. And again, this is the reverse of the previous question. So very few children with ADHD were not problematic on these issues according to their parents. At what time of the day were the problems with homework? Of course, not at lunchtime, because then the child is at school, but also early afternoon, late afternoon, and also late in the evening. When were the problems with playing with other children? Starting at lunchtime, early afternoon, late afternoon, and in the evening. Striking differences between ADHD and non-ADHD. Already at lunchtime, more problems in following family routines, more problems with ADHD, early in the afternoon more problems, all over the day, also late in the evening. Relationships problems, very few, less than about 5% of all children with ADHD didn't give rise to relationships problems, in contrast to 40% of the normals. And so for many children with ADHD, parents reported problems in the child-parent relationship, with a very stable difference between ADHD and non-ADHD at lunchtime, early, late afternoon, evening, and see this huge difference at bedtime. It's a very huge scarring difference. More than 50% have serious problems in the child-parent relationship. Relationship with their siblings, similar figures, huge differences. Excessively demanding, it's the same story for all those items, and it's in fact very impressive. Being noisy and disruptive, again, striking differences between ADHD and non-ADHD. It starts at lunchtime, and huge differences in the early, late afternoon, late evening, and also at bedtime. Being aggressive and defiant, similar data. So let me take you again, let me again discuss with you this slide on the 4 medication groups, because so there are I think minor differences, few differences between the different medication groups, but this signals that particularly already early in the morning, all children with ADHD have more problems than non-ADHD children, and that particularly those on long-acting medications have problems over the whole day, in the late evening, and at bedtime. So when we asked parents at which time of the day you like to have the symptoms of your child better treated, 30% would have better treatments at lunchtime, even more, close to 50% better treatments early afternoon, a huge number late afternoon, late evening, and at bedtime. And so many parents have a critical need of having better treatment options, better symptom control. You could have the impression that most parents were not satisfied with medication, and that's not true at all. So if we ask them to give a general rating of their satisfaction with the medication, general rating, and you see here the figures, the average is 5, meaning satisfied on a scale from 1 to 7. 15% was extremely satisfied, and so most parents were in the category 5 to 6, satisfied to very satisfied. And so meaning that we, in fact, by having this survey, challenge them to be very critical, to say, well, what would be my best option in the most optimal world? Again, yeah, I'm satisfied, but I have the feeling it could be better, and particularly in the late afternoon, late evening, and around bedtime. So I already preluded a little bit to these caveats. So the differences between the treated and untreated children were small. This study was not randomized, so it's a caveat. It should be a descriptive study, and there is a clear signal in the data suggesting that those on medication were the more severe cases. They had already problems early in the morning. Of course, we had already also may have expectancy effects in the parents. Those on treatment may still have reported the most worst days of their child and not the best days. And of course, we do not have further information about the compliance with the medication and how well the medication was prescribed and controlled for. In spite of these caveats, we can come to some conclusions. So most parents reported reasonable satisfaction, although they experienced significant problems with their child in activities, relationships problems, at various times of the day, and mainly throughout the whole day. And particularly the afternoon and evening are very challenging periods of the day. Doing homework, having a nice time with your parents and your siblings. And so many children with ADHD continue to experience those problems despite receiving drug treatment. And I think this is in line with some other data, like the MTA study. And this shows to us that we are still far away from having the ideal, optimized treatment. We have very good options. We have medication. Dr. Cockhill will speak later on in extenso about medication and all kinds of medication algorithms. We have school treatments, will be topic of the other lecture. We have all the kinds of treatment, but we should not be too satisfied too early. We should continue to work for improving those problems with the families. And so the take-home message of this lecture for you is in fact to be sensitive to this. And also as a clinician in your office, you should ask more specific questions about what's happening around early morning routines, what's happening before school, lunchtime, early evening hours, late evening hours, and bedtime. And this may give you much more clues about what's happening in a family, and so to titrate your treatment and to optimize your treatment to the specific problems families experience with children with ADHD. Thank you.